Hey everybody, welcome back to Standby for Tones podcast. With you like always, you got myself, Isaac Baker, and our favorite guy, Mr. Sam Schwab.
Hello.
How we doing, man?
Oh, good, man. It's been a long day.
Yeah.
It's
been a good day.
Yeah, it's been a good day. You know, we're hitting that probably our fourth fake springtime, hoping it sticks around a little bit. I'm already in my dad golf attire, shorts, polo, flip-flops. Ready for the world, man.
Yeah, absolutely.
Ready for a hot helicopter season. Good Lord.
Yeah.
Hot helicopters.
And with that comes trauma season.
Yes. And trauma season is already in full swing, man. I mean,
feels like it.
We've had some pretty wild calls recently.
Yeah.
But, time will tell.
Yep.
I mean, come, Memorial Day that we started our 100 Deadliest Days?
I think so.
Yeah, one of those holidays. I don't know if the other states in the world do 100 Deadliest Days, but it's a big deal around the Idaho area.
Oh, for sure.
Of, keeping people safe. It brings awareness and, our numbers continue to trend upwards for our deadliest days of summer. But I think there was a couple lulls. But, motorcycles, UTVs, all these things get faster and more powerful. Throw people that think they know what they're doing behind them, and then this is where we end up, in a helicopter or ambulance or,
No, absolutely. Obviously, we want people to be safe, so make sure you're being safe, but
have fun.
Something bad's going to happen, just make sure I'm working. So.
That's bold, man.
I know. Before we get too far into today's podcast, like I always want to talk about our stuff first, so make sure you guys go check out the website, www.standbyfortones.com. You can always find our book, which I'm going to hold up. Realized I haven't held it up yet and looked at it. It's so pretty.
It is very pretty. I like the
colors.
colors.
Very pretty. It's awesome. Go check that out. You can find it on Amazon. Just search for Isaac or Sam. It's the easiest way to find that we found. Also there, we also have our little critical care flight log book as well. It's most beginning pages are all going to be just for that, for your flight log, for your patients. It's got some awesome spots for labs as well as medications. Got a nice space to write whatever you want. And they're really nice. And in the back, you'll find nice little quick tips. You find things like your Van stroke scale, rule of nines. You've got your pupils.
I think the number one thing that people love is the medication compatibility chart in there.
I love it. I used it the other day, actually.
Yep. We have a whole medication compatibility chart with the most commonly used EMS medications. So
yeah, there's a few I want to add to the next time we do it, but for as far as space went, what I could fit in there is pretty dang good, and it works out really nice. So
I like that book too because it's it's a perfect size for a pocket. It fits in my flight suit breast pocket really well.
It does, and it's held up really good. I've used the heck out of mine.
Mm-hmm. I'm pretty terrible about using it. I'm such a tape fan, man. So,
I like to use it, especially when I'm doing vent calculations and stuff like that, and it helps for charting, or if I do old school math, nurse math with finding my constants and doing stuff for a lot of my pressors and things like that. So, no, they're really good. Make sure you guys go check them out, pick one up.
Yeah, we've gotten a lot of good feedback on these books. One of the biggest things that is, if you do buy it and you like it, please leave a review on it because,
absolutely.
We want to bring this education to as many people as we can. So the more reviews that we can get, the more that we're seen, the more that, we can improve things, because if people like it, we'll keep improving it.
Yeah,
I mean, we're going to probably do it because that book took us forever to make.
It did.
But it was worth it in the end, right? So
absolutely. And we'll already have ideas of doing different versions as well. So you may not need the full flight log critical care version. So we'll have a EMS, paramedic, EMT type versions as well coming out. So
all things to come. And then I got one thing for them too, is something that we don't promote a whole lot. We'll pull it up on the screen, but we actually have an app that goes with our course, and we like free things because the more free things we can give you, the more we feel like you're going to be able to study. Yes, our courses are paid, but, we offer a lot of free things. So we have an app. If you go to the Google Play Store or the Apple App Store, type in SB4T. This is kind of a little bit of a love-hate relationship between me and the app because I spend a lot of time putting stuff in there, and sometimes it looks really good. Sometimes it's a work in progress. So we're continually adding things, trying to do it monthly. But right now what we have in there is we have cardiac rhythm interpretation. We have an entire pharmacology, I'll say a fancy word, pharmacopoeia
there you go.
Section in there where you can go through and get, national standard drug dosaging for EMS providers. We've got flashcards. We've got quizzes. Some of my favorite things is we put direct links into the National Weather Service app so you can see every airport in the United States and the weather in real time, so that if you ever have any questions or, maybe you want to do a little research and looking where you're going yourself to see what you're going to be encountering through your flight, you can pull it up quickly.
Yep. There's
a direct link to Flight Radar 24 in there so you can see the aircraft coming in and around your area. And then we have checklists. So there's an RSI checklist, pre-departure checklist, a landing checklist. I'm working on the lab values section right now, so that one's kind of bare, but it's getting there. And then you can find our entire reference list in there. So if you ever have any questions about where we get stuff for our books, our classes, our website, that's a rolling document that I keep updated monthly.
Yep, absolutely. And yeah, like I said, work in progress. We're always trying to make it better, but no, it works out nice. And I mean, I like the flashcards and the quizzes.
Yeah. We're going to be changing the quizzes up a little bit. The in-app quiz builder is not the greatest in the world.
Yeah.
And it just is really hard for me to go in and change and kind of look at. So we're going to do some adapting to that. But yeah, that's what I got. Things are going good, man.
They are.
This whole thing is going really good for us so far. I mean, we're getting people to be engaged. We're getting people in courses. I see people taking tests every day. And we just want to get that reach a little bit more. So continue on, continue learning, continue listening, continue sharing.
Absolutely.
We love interacting with people too. I get messages a couple times a month from people. So it's really been kind of a fun thing for us.
It is. Yeah. And that's one of my favorite things about so far what we've been doing, especially with the podcast, is just the questions and the conversations they get to have with providers afterwards.
90% of the podcast.
Fire of ideas and then when they come with questions that I don't know the answer to, it works really good for me because now I get to find out something new. So
yep. And that's why we have a medical director too.
That's right.
Because there's some questions that I still don't know how to answer, like sodium bicarb, when and where. Still don't know exactly when to do that besides, tricyclic overdoses. There's no clear answer. But, a lot of our podcasts are driven by our viewers and questions that they ask us. So keep sending us questions, interacting with us on Facebook, and we'll keep these going because these are fun for us.
Yeah, absolutely.
We got a good bunch of things to talk about today.
We do. We have some fun stuff. One of the things, we'll just jump right into it today, is talking about some seizures. I love me some seizures. So something I've been wanting to talk about for a while because they are some of my favorite patients. They're crazy. So
they're so crazy. I'm sorry I'm laughing, but
I know why you're laughing because we had some good conversation. We've both recently had some really interesting seizure calls, which we're going to talk about.
Yeah.
But one of the things I want to talk about really is kind of that like real or fake.
Yeah.
Which we will
part first.
We'll get into. Get into because a lot of times it's hard. There are some people who are really, really good at faking seizures.
Yes.
Right.
You tell them to pee themselves next time to fake it. They're gonna pull out all the stops. Right.
Oh my gosh. And I know a lot of people are like, I know what you're talking about, but it's hard because I feel like a majority of the seizure patients we go on, they aren't little kids having febrile seizures. Mm-hmm. For the most part, a lot of them are not real, right?
Yeah.
I mean, you get how many pseudo seizures? Yeah. I don't know how many I used to get on the ambulance. Don't see it as much on the helicopter.
Nope.
Which is good. Still had a few, transported a few.
Yeah. I mean,
but for the most part, on the ground, I mean, we run into that all the time.
Yeah. No, it's a very frequent call that we seem to run. And one of the things that people talk about too, because I know you had a patient like this. I haven't seen one where they're still talking through their actual seizure. Just because they're talking and, have rhythmic motion doesn't mean that they're not seizing. I mean, there's special parts of the brain that could be getting activated.
Correct.
And they could be spitting out some words or have a large yell scream that makes you crap your pants. There's a lot of things. We'll talk about these, but
yeah, that's on my list of, I have those labeled under the WTF seizures.
Yes. Oh, perfect. So, but yeah, I mean, it's a very frequent call and there's a lot of ways to determine that it's real and a lot of ways to determine that it's not. And sometimes you just can't tell the difference, and it's hard.
And there's, a lot of patients you're treating like it's a real seizure, and sometimes that's what we have to do. And that's sometimes you err on the side of caution. You give them the benzo, and we go on with your day.
Yep.
But for me, one of the things after my last seizure patient that I had was just kind of a description, I guess, that formed in my mind of what's real and what's not. Was thinking about pseudo seizures and these fake seizures is I feel like those are always very dramatic, right? They're always shaking like crazy.
Yep.
Whatever it is. They just seem very dramatic, right? The patient usually looks pink, great. Yep. They're breathing through it just fine. Right, their heart rate doesn't change that much.
Yeah.
And it is just, like I said, very dramatic. Whereas seeing a lot of actual real seizures, I describe those more as pathetic.
Yeah.
They really do look pathetic and miserable.
Yeah.
And that's, for me, that's one way I kind of look at those as far as, okay, is this real or not? Is this dramatic thing, or is it a pathetic thing?
Yeah. Not saying that the dramatic ones aren't real.
Correct.
Every once in a while, but it's a lot less frequent. I mean, You're going to get that rhythmic muscle spasming and tightening up.
Correct.
I mean, like, a true seizure patient is normally going to bite the shit out of their tongue. I mean, like,
it does
they're
happen.
going to start bleeding. They're going to have injury patterns, because most of the time the real seizure patients aren't trying to protect themselves. Those dramatic ones,
they do.
They're lifting their head off the ground the entire time, trying to protect their head from slamming it against concrete. And, most of these actual seizure patients are going to have either some form of traumatic injury from falling, because they're going to be standing or sitting in a chair.
Yep.
Nobody around to catch them, and they're going to have some form of pattern. So these are little cues that we look at as we, do these seizure patients.
We do. And you watch, like I said, I love seizures. I don't understand them at all as much as I want to. I would love to be able to get more into that and do some EEG stuff and always trying to get a better understanding of what's actually going on with the patient. Yeah. But a lot of times you'll see that where they start out vocally or small and then grow into that large seizure, or you'll just see those sometimes complete absent seizures as well.
Yeah.
I remember my neighbor, she had absent seizures, and it was interesting to watch her have one where she just kind of stood there, lips just kind of turned blue, and dropped her pizza that she was holding, and then just kind of like picked up her pizza and kept going on, and it was obvious that she had no idea what was going on. It was like, oh, she's had a seizure. It's kind of cool.
And,
but,
and it's really hard to fake a postictal state.
It is.
Like, or as Microsoft Word calls it when you're trying to type it out, it's poetical. But it's really hard to fake those poetical states. I mean, like, they range so drastically too. Because like my last one, like as soon as the seizure stopped, he was doing that big, like, gasping, like pursed lip, like horse flapping mouth, like spit and blood and drool everywhere, and then was just out of it for a long period of time. And Correct. It's really hard to fake that.
It is. And then a lot of times with that confusion then comes the combative aftermath.
Yes. Oh, right? Boy.
Which is fun.
Yep. It's always fun. I hear a helicopter flying over.
I remember we were talking, so just again, going back to some of the seizures experiences we've had. I remember we were talking and laughing, but I remember my very first seizure that I saw was, it still haunts me.
My last one's going to stay with me for a while, man. So let's hear it.
No, it was great. It was this, I was doing ER rotation, doing a clinical, and in the room with this lady who was there for seizures. And it was like, okay, so she was totally fine. And she was this like scary looking old lady.
Yeah.
Like white hair, like skinny, kind of like pointy nose face, just kind of mean looking.
Like the typical drawing of the old witch.
Oh yeah.
Yeah.
And then, and just out of the blue, she was just kind of staring at me and then just screamed. Just this horrible scream. And then the next thing I know is like she's still screaming, and then she just bites down on her tongue and blood goes everywhere, and then she just starts violently going at it. I'm just like,
sorry for laughing.
Oh, dude, you're totally fine. It's hilarious. Not for
her,
But oh my gosh. So that was the very first one I ever saw. And that was like, and then she went full on tonic-clonic,
Yeah.
And, but like scared the crap out of me, new medic student and all that. Oh my gosh.
Their seizures can be scary, man. I mean,
be.
like, especially like, just like these incidental ones. Like, I'll tell you my story here in a minute, but I mean, like these patients that have like true status epilepticus. Because one of the saddest cases I ever had was a, early 20-year-old gal that, had status seizures, had one of those really cool, like, it almost looked like a padded swimming pool bed in her room. Like, went about her normal day, but she had her seizures at night, but had one that lasted all night, and parents didn't notice. And, it's one of those things where it's like, this has happened for her entire 20 plus years of life. Like, we've kind of got it on board. Then she had, an anoxic brain injury, went into an arrest, and, it was a really sad story, but, it's just so crazy how different every single different seizure can be.
Yes.
So I had, on the topic of scary seizures, I had one a little while ago, and get called for a car accident. And, we're thinking, okay, like we're going for a car accident. They said he's been outside for a while, the typical thing. And we get there and we're actually landing at the front of a residence. And as we're landing, we're like, oh, there's where the accident happened. Like, you can see tire marks going across the road. And then I was like, but there's no car. Like, what is going on? This is super confusing. So get out, go make patient contact. They had brought him to his garage. And we get out, and lo and behold, here's this guy sitting there just like shivering like crazy, and things that I didn't cue into right away, because like I get down, I'm talking to him. He just doesn't seem all the way there. He's answering all of my questions appropriately, but he's just not all the way there. And so talking to him, asking him if he's wet, did he walk through the snow, blah, 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 blah. And one of the gals was just like, oh yeah, he spilled a bottle of water from his truck on his lap. His pants are wet. And that was a key that went right over my head. Yeah. Like, little did I know that was going to be, urinary incontinence from a seizure.
Correct.
And, put a 4-lead on him really quick, waiting to figure out how to move him through the mud and all this stuff. So I'm just getting my basic vital signs, getting a line started. And his heart rate is just 140 beats a minute, just tacking along, just no stopping. Like, usually there's some variation, like in these heart rates. I'm like, that's kind of weird. Like, your heart rate's really high. Like, it's quite high. And so I'm like, is this a cardiac related issue? Is it not? Not quite sure what's going on. Haven't put all the pieces of these puzzles together. So the ambulance shows up so they can help us move him through the mud. Put our flight bed on that stretcher so it was one less movement, and we get him strapped down. Picking up my bag, and I had my back turned for like a split second, and all I hear is this demon screech of like the most annoying sound in the world, from Dumb and Dumber. Right. Like, oh my God, like it was the most terrifying thing. I'm pretty sure not only did I need a new flight suit from what happened next, but like pretty sure I crapped myself in the moment. And my partner's like, is he pooping? And I'm just like, no, I don't think he's pooping. Like,
I did.
Like, I did. But, like, his heart rate now is 180. He's, bit the heck out of his tongue. He's spitting blood everywhere. Like, going full exorcism style on me, and just completely clenched down, just doing that scream, and then just that rhythmic motion started. And we were like, that's what happened.
Gotcha.
Like, and it wasn't until we were done charting that we were like, oh, that wet lap was from that's urinary incontinence. So we get him in the helicopter, and he's going through his postictal phase. We're trying to talk him through it, and he just becomes, just really angry at us, like unbuckling seat belts, kicking at us, pulled his IV out, sprayed blood all over me. I fly with my shield down most of the time, which is I'm thankful for, because he's spitting blood at me. It's getting on my shield. Like, I'm keeping my, as turned as I can. And, there's blood running everywhere, and it's this biggest disaster. Like, all of my monitoring equipment's off. I'm telling the pilot, like, hey, he's half unbuckled. I mean, we're able to maintain him. He's basically telling me to F off the entire time. And I'm just like the patient is angry at us. Yep. Luckily, we were able to get 2 milligrams of Ativan into him before his IV came out. And then he pulled his IV out. So we were like, well, I guess it's time for intranasal Versed. And we finally got him to calm down. So don't forget about your intranasal Versed in these seizure patients, because it works really well. We finally got him to calm down a little bit. We're able to talk him through, and we were like, hey, man, you had a really significant seizure. And what was weird to me was like, oh, is that why I crashed my car? Like, I was like, holy shit, like, you remember that? Like, you just went through all of that and you remember all the way back to that? And we were like, that's probably why. And, turns out that there was an alcohol issue and some time in between. So this was probably, like a withdrawal seizure of some sort, which, our primary treatment in withdrawals, which explains like the jitteriness that we thought was, our shivering and like, cause I mean, we were getting ready to use the QuinFlow and give him some warm fluid. And I was just like, I'm going to take a temp on him really quick. And it was 100.2. And I was just like, well, now is there some infectious process, like all of these other things that weren't quite adding up until that seizure actually happened in front of us.
Yeah.
But yeah, I mean, like, it was a wild. I've never been so tired after a 20-minute flight back to, and I'm just defeated completely.
Oh, yeah, totally. Like, no, I feel one of my least proud moments in EMS, and like, just what I get was a seizure patient who get there, he's completely out of it, post-ictal. Girlfriend called, we get him in the ambulance, start getting IV, start rolling to the hospital and start trying to get an IV. And that's when he like snaps out of it and then is just pissed because he has no idea what's going on. And he's now just like, why am I here? And I can't convince him that he had a seizure. It's like, dude, you had a seizure. And it's F you. No, I didn't. It's like, okay. Yes, you did. It's all right, man. You're good. We're just starting an IV. F you. Yeah. And finally, it was just like, enough. Like, you know what? F you.
Yeah. See, and that's I ran into that problem too, because I'm like, I'm sitting there, I'm getting angry at this old man that is withdrawing from alcohol.
Yeah.
Like, and I am angry at him, and I don't get angry often. And, these patients can't control this state, but it's just like, sometimes I had to use that little bit of anger to make him be like, oh, okay. Like, yeah, it happened. Like,
oh yeah. It was like the most, worthless ride. 'Cause it was just me and him basically telling each other to F you. It's like, you really think? I'm like, dude, you're right. You're not in an ambulance going to the hospital. Yeah. I decided to come in and kidnap you in your underwear and take you off somewhere. Like,
yeah. And then just like the thought of it, like that is so funny, because then you add a helicopter into it, and how big of a component is that? Like, these patients come out of this post-ictal state in their anger, and now they're, a couple 1,000 feet above the ground going 200 miles an hour wearing a headset in the back of a goddamn helicopter. Like, they're going to be terrified. And it's hard to communicate that to a post-ictal GCS of like maybe 8 when they're waking up.
It's hard enough to communicate in the ambulance or on scene or whatever it is. But now you add, again, the helicopter where you can't talk.
Yeah.
It's super loud. Yeah. And the headsets are, you have to have that mic position just perfect to be able to talk to somebody. And oh my gosh. Yeah.
And we're lucky to where we have a headset for our patients. Like, a lot of agencies won't carry a headset because they don't have a way to isolate them. Correct. And like, so, you're yelling back and forth, and, and I just think about my time in like the smaller aircrafts too. Like how do you manage somebody that is kicking and screaming in something that's like an A-star or a 206 or a 407 where their patient legs are right next to the flight controls? Like, you have to be really on top of your game and keeping these patients well sedated, because like, if I had that patient at a 407, I was talking to Chris about it, because he was like, how would you manage that? And at that point, like where he was that agitated, I probably would have had the pilot put it on the ground so I could manage them in a safe manner.
Had to land for sure.
Yeah, and put the aircraft on the ground, sedate them. Don't want to give them ketamine, because that's just going to induce some other trip. Like yes, it's a great anti-epileptic. I understand that, but our benzos have been proven to work for so many years in managing these things. So
correct. And that was another. We'll just go right into it, since you're talking about benzos and how. Just wanted to talk about some different seizure medications that we use and how actually benzos work, and things like Keppra, which I love giving Keppra to seizure patients. Obviously, we don't always carry it.
I wish we carried it.
I wish we carried it ourselves, but make sure it's something you can always ask for at the hospital if they haven't done it. A lot of times they're pretty good about getting those seizure patients, loaded up with Keppra, but it's a great drug to either have in your tool bag or make sure that it's being used. But how do benzos actually work?
That's a great question, and I'm glad that you researched this. But my knowledge of benzos goes to, going back to, GABA receptors and cellular, trying to reduce the noxious stimuli that's going in and out of those, those neuron cells more than anything.
Right, and that's what I remember just from paramedic school was like GABA. Okay,
yeah, it's cool. GABA.
GABA. That was a test question. Yeah, it's GABA receptors, right? But what does that mean? All right, so yeah, doing some more research and getting into it. So as far as those GABA receptors, basically, what those benzos are going to do are going to help kind of stabilize that those membranes for those neurons, right? Basically, they're going to cause this influx of chloride and release of potassium, get the neuron negatively charged, and just overall stabilize the membrane, which leads to decreased neural firing.
I like that.
So
it was a good way to explain that.
Hopefully.
We try our best, ladies and gentlemen.
Right.
We're real good triers.
Whereas now something like Keppra is going to work differently. Right, and that's another benefit to having multiple different seizure medications. Your benzos to stop that, and then your Keppra to help stop those from starting again. So Keppra is going to work differently, right? It's going to help stabilize the electrical activity in the brain by basically inhibiting or decreasing inhibiting the neurotransmitters. So long crazy answer is it stabilizes electrical activity in the brain by way of synaptic vesicle protein 2A, which means nothing, right, to us.
I ain't no doctor.
But basically, it's involved in the release of chemical messengers. So it's going to decrease the amount of neurotransmitters that are being released.
Okay.
Right? So now that you have less neurotransmitters being released, it's going to help stabilize everything so that they're not firing so rapidly.
Yeah. So it kind of brings up the thought of have you ever had a patient with the VNS device, the vagal nerve stimulator?
Yes.
Those are wild, man.
They are. And that's a different type of seizure that we'll talk about that a little bit too.
Yeah.
So those are going to be more, let me look it up here. Let's see.
The patients that I've seen them dropped in most is those congenital seizures, the lifelong, the true status epilepticus patients. Mom's got the wristband.
Yep.
Patient has the pacemaker device that's implanted. So
pacemaker
or the pacemaker. It's a pacemaker-like device.
Correct.
Is the only way that I can put it because it feels like a pacemaker underneath the skin, but it's not. It's about the same size, still implanted, and they're really cool devices. And when they're activated, the biggest thing is, you're going to see that that heart rate start to come down. You're going to start stimulating or reducing that stimuli, and they're going to start coming out of these seizures, which is really crazy to me that we have an implantable device that works that way.
I'm trying to find, I had this brought up, which type of seizures those are actually in.
All mine says is the treatment of epilepsy and depression.
It's again very congenital stuff. I think it has more to do with the developmental scars in the brain, whether that's from trauma, stroke, meningitis, but usually from early onset, and they end up getting those stimulators.
Yeah.
Which sometimes work really good. Sometimes it takes a while for them to work. But in those situations, I feel like the parents are always a great resource, right? Because they know more than you do when it comes to that and how what's different, and how that child should be treated.
Yeah.
So always use that resource. Use the parents.
Yep.
Caregiver who's there if they know that stuff.
Yeah. And one of the things with the vagal nerve stimulator too is it gives off of that steady, rapid stimulus is really the primary function that it's there for, and to kind of block out those those seizure tendencies and those random electrical firings and those random nerve cells just kind of going off and creating that flash and that effect of the cameras and like a big concert where they're just flashing. So it's almost like override pacing is the way I kind of think of the vagal nerve stimulator. And, they're a cool device. We don't see them as much.
No, not very often, but do see those. And those are usually when you have those guys, there's no question of real or not real, right?
Yeah, one of the hardest seizure patients I ever had was a little kind of Michelin man looking kid, like 3 years old and nothing but fluff. And so no IV access, status seizures. Mom's very, very good with her history. Ended up having to IO the kid. He got rectal Valium, got, Versed, got all of these things and ended up not being able to stop it and got intubated and flown to a pediatric center. Like it's a big deal for these congenital seizures. And, this kid had that VNS device and it wasn't breaking it. So this was a hell of a seizure that was going through.
Yeah. And unfortunately those do happen. When you see them that's the same one you say you end up innovating and doing all that stuff just because you can't break it. One of the things we talk about just education wise for kids, especially if you do have to intubate them and watching those kids is just continue to watch for seizure activity, right? Because remember, you don't always get the same, especially with pediatrics, you're not going to have the same type of symptoms as you do with adults. So with those kids, you may just see some of that little bit of like chewing as well. I always grab their wrists, especially if we've intubated them, whatever, and just kind of hold on to their wrist for a minute, as long as they're not having a neuromuscular blocker rock or whatever on board, and just seeing, because sometimes you'll get just the tiny little twitches that you don't even see, but you have to actually just feel them, and then always looking at the eyes as well.
Get that eye flicker. Sometimes like if they're not intubated, they'll do like the bicycling or the lip smacking is another big one, and especially in like the infantile age range. That rhythmic lip smacking. There's so many indicators that it's kind of hard to keep up with them all sometimes. But,
it is, and it's just make sure you're continuously checking those guys and watching for those just little subtle signs, because they're much different than the adults. So
and don't forget to check blood sugars, please.
Blood sugars, right? That's another. We'll talk about the causes of seizures as well. But with that, there's so many types of seizures. Looking through it all, can't explain them all. Trying to come up with definitions for all of them, right? But we have, obviously the pseudo seizures, which are not real. I think I look at pseudo seizures. I look at two types of pseudo seizures. Personally, I don't know if this is right or wrong.
Okay,
but
let's hear it.
The way I see it is obviously your pseudo seizures, the ones that you're faking it straight up. That's what I call a pseudo seizure.
Trying to get out of PE class.
Right. I call, or just attention. Or whatever it is. Right. Then you have, I feel like, some psych induced seizures, which are more real. Right. They're actually a type of seizure. I don't know. And this is just me classifying it that way. I don't know what the right classification is for that, but where it is some sort of psych thing, right? And they actually have this seizure that does cause them to have problems. And like the last one I took was, should probably check my camera. So back at it. So like the last one I took was, I think they were really kind of classifying it as more psych than an actual, and they're getting that off the EEG. But where I watched this patient who's just sitting there totally fine, and then the heart rate goes from like 90 to like 130 all of a sudden, and then you just get that kind of pause, and then it just starts in one spot and slowly works its way out through the body, and you get this big storm, and it's just like, but they don't see anything on the EEG. It's really weird. But then totally postictal, and you can't stop it unless you get benzos. So it makes no sense to me.
No.
I don't know how they classify that, but that's what I think of when it's a psych-induced seizure, I guess. So not getting the normal EEG findings that you would, but it's still very detrimental as far as, it looks very real, and it seems very real. So then you have things like your absent seizures, also known as your petit mal. You have clonic or your myoclonic. You've got focal, partial. you've got your tonic-clonic or grand mal seizures, right? And then we talked about the WTF seizures, another awesome seizure story. Get called for a guy having seizures, get him an ambulance, start going to the hospital, talking to him, and literally the right side of his face starts thumping, right? Just starts just complete twitching on one side of his face, and he's still having a conversation with me.
Yeah.
Has no idea that it's going on. We're talking, and I'm just like, what is going on? Okay. Christ compels you here. Starting to go on and then, then the right arm starts going, and still no acknowledgement or even realizing that it's going on. It's like, wow, you're having the weirdest seizure I've ever seen in my life.
Yeah.
And so, give him some for his head and stops it. But it's just like, what is that?
Yeah.
I didn't even know that was possible.
Yeah. So, I remember that case from one of our chart reviews with our old medical director. And he was just like, this is weird. And the fact that you've seen this and it's like a very limited documented thing.
Yeah.
And then it was confirmed by lab values, because we can tell if a patient's actually had a seizure. You pull their CK, you pull their CRP, all of these different lab values.
Probably
lactate as well. Yeah. See how much their muscle involvement has been used, see how much inflammatory response they've been having, all of these things. So we can tell if they're true or not, which is, kind of a really incredible thing, especially for the ones that are truly actively having them. And to have him come back and be like, all of these were there and that this actually happened and he was still talking to you, it just shows how crazy it is that these little, neurons can fire off in just random specific spots in your brain and just affect this little tiny part. And then him being able to hold up an entire conversation with you, not really go through a postictal phase, but then have a confirmed seizure based off of lab values is insane.
Yeah. Weirdest thing I've ever seen.
Yeah.
Truly.
Dude, seizures are just weird in general.
They are. And we're talking about some of the causes. Just jump in.
Oh yeah. So
as we go. So,
one of the other ones too that we don't see all that often is hyponatremia. We hear about sodium and how important it is in the body. But, our normal sodium level is supposed to be 135 to 145. So some of the things that we need to go over that can cause these hyponatremic seizures are, I'm going to pull up a list here because I have a good list of them for learning points. Let me pull it up really quick. So some of the things, that we're looking at is just drinking too much water. That's right off the top of the head. Overhydration, dilutional hyponatremia. We got all these buff guys out in the summertime drinking 4 gallons of water. They're at a chance of having a seizure, right? Then having too little of sodium in your diet can, have an alteration of it. But then there's big things like diuretics. There's antidepressants. You could have kidney problems, liver problems. Anybody that can go through a hormonal change or hormonal imbalance. And then there's other things like forceful induced vomiting, our bulimia patients, severe diarrhea, recreational drug use, ecstasy, all of these things that will promote your body to eat up every, electrolyte in your body are going to cause these things. And they're going to be really hard to spot. And, it's one of those things that you probably aren't really actually going to spot what's happening unless you have that bulimic patient that comes to you and says, hey, I'm a bulimic and I throw up 18 times a day and I had a seizure. And it's okay, we probably have a little low sodium. Yeah. Let's get some, some normal saline running on you. I wouldn't necessarily go to the full 3% by any stretch, unless it's an ICU patient, leaving known hyponatremic with a sodium of 80. And then you notice a seizure and you start giving them a sodium replacement, but that would be a med control call and all the things. Yeah,
totally. So, I'm not sure on that. I've wondered that a few times as far as when do we start treating that or how do we treat that?
Yeah,
I haven't had the treatment. I've seen multiple low sodiums.
Yeah.
It's
So usually the treatment path comes as they start to get symptomatic is more or less the thing. Cause there's a whole gradient. They'll start getting listless and then they'll start to, kind of alter out and then they'll start having seizures is kind of their final stage. And that's really kind of in that range is where treatment starts is from what I had done at previous programs. So, because we actually had a hyponatremia section, for part of our seizures, which was pretty cool just for interfacility stuff. And, there's just so many different types out there. I mean, then you got your hypoglycemic patients. Like
you got hypoglycemia, and actually going back to lab values too. Another one, hypocalcemia as well. Had one recently where it seemed like he just was having seizures and weird stuff, and saw that his calcium was low.
Yeah.
We transported him once to a facility, realized like, whoa, this is way beyond our capability actually. So sorry guys, you're going again, and transported again. But in that time that we seen him, his calcium had dropped almost like, I don't remember, he went from like an 8.5 to like a 7.0 or some ridiculously pretty low calcium.
Yeah, a significant drop.
Like, wow, and it was pretty interesting, all of the side effects that we were seeing with that. And it's like, hey, let's do something about this calcium, treat the calcium, and that stuff went away. So I was like, well, pretty interesting. So
love that.
I didn't know about that until we looked up that he had that hypocalcemia and kind of some of the side effects, and said, wow, seizures and kind of muscle tetany and different stuff like that. Like, I think that's what's going on.
Yeah, it's the seizure. We opened a huge can of worms on this topic, man. I mean, like, we're 40 minutes into this conversation and we haven't even finished seizures yet.
No,
so like it's
continuing. Hypoglycemia, right? You'll see them when they get real low. They'll start to seize. The last one I saw, I mean, he was so low, just red low. That's all. And then he had looked like a full on lagoon of sweat on his chest. Ugh. But having seizures, see that occasionally with that. Obviously, treatment for that's going to be
your dextrose.
There you go.
Yep.
Dextrose.
Yep. Unless they've been anoxic forever, and then you're dealing with a whole another cup of worms and all those things. But predominantly it's dextrose.
If you can't get a line, you can give them Rectos.
Snickers bar up the butt. Yep. Everybody's heard of a paramedic somewhere putting a Snicker bar up somebody's butt on a camping trip. So it's pretty awkward.
I haven't, but I have now. So now we all have too. But another thing with kids, we see it a lot.
Yep.
Febrile seizures, right?
Yep.
Remember, it's usually not how high it goes, but how rapid it changes.
Yep.
And something to remember with that as well is not only up, but down.
Yep.
So if you're treating this kid who's had a febrile seizure and now their temp is 102, you don't need to drop them to 98 rapidly.
Yeah.
Right?
Yeah, that's and one of the things on that too, we'll go to temperatures here just for a second. On kids, I got burnt really bad one time. I had an infant, or I'd say a toddler, more or less than anything, having a nasty febrile seizure. I took an axillary temp, and it came back at like 99, and I drop him off in the ER, and I'm just like, okay, like febrile seizure, blah, 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 temperature's around 99, and they all looked at me, and they're like, are you dumb? I'm just like, well, I tend to think not, but there are times there is chance for improvement, yes, and they're like, come with us, and they grabbed me by the hand like the little paramedic that I am, and they said, go stick that thermometer in that kid's butt for us. And I was just like, really? They're like, yeah. And that rectal core temp came back at like 104.8.
Holy
on
crap.
The same patient that I had just got an axillary temp on.
Yeah.
And they said, if you ever bring me a temperature that is axillary on a toddler or an infant, and they've had a febrile seizure, like, don't even bother telling us the temperature unless it's a core temp. I'm just like, sir, yes, sir. Like seeing like a 6 to 8 degree difference was like, it was mind blowing. The kid was fine, came out of it fine, but like they had to drive that learning lesson home. And I'm very appreciative of those things that they do that, because I mean, like on those kids, like I had probably last year, I was with old Josh, and we walk in, he's like, you really going to do a rectal? I'm just like, yeah. And it came back at like 103.6 or something like that. He's super postictal, and I was able to give him a core temp and, did a bunch of pull push fluids, and the kid was doing a lot better by the time we got there. And so, yeah, take those rectal temps. It's not the end of the planet.
Nope. And what else we got? What else causes squeezers?
What else causes squeezers?
We talked about your withdrawals.
Yep. Right? Lights, sounds. To a degree.
Obviously you have your histories, so some people can get that because of that. But so remember, you have things like trauma.
Yep.
Stroke.
Yeah. So those are the things you're looking for me to say.
That's what I'm looking for. Trauma, stroke, things like meningitis.
Yep.
Right. Again, usually that's going to be maybe something in the past, maybe not happening right now that has caused that. Obviously, you have trauma that happens, then you can have seizures because of that trauma.
The little old lady on blood thinners that fell and bonked her head 3 days ago.
Yep.
That now just filled her cranial vault full of blood.
That's right. Remember, we always look at if somebody's having a stroke or not. Remember, seizure is one of those things too that we want to rule out, because if they had a seizure and now they're having stroke-like symptoms.
Todd's paralysis.
Had multiple of those, actually.
Damn, it feels good to be a gangster. Just glad I knew that part.
That's good.
So, those are all really good, man. You really went above and beyond on that section.
Trying.
Seizures is hard, man.
It is. They're, like I said, that's why I like them so much, because I find them really interesting, especially when you see someone having one of those WTF seizures.
Withdrawal. Sorry, go ahead.
Go ahead.
The withdrawals is a big one, because it's not something that I think about all that often. To be completely honest, the withdrawal seizure on my last patient was probably at least like step W in my assessment plan at that point, until like it, batted, or it was up to bat, knocked it out of the park, and ran around home base right in front of me before I got to that point. And seizures can be very humbling in these situations.
They can. Oh, for sure.
Because they're unexpected, like, especially when you're actually witnessing them, because how often do we actually get to witness the seizure activity?
Yeah. A lot of times you're trying to figure out why are they altered?
Yeah.
Right.
And you're going through your AEIOU tips type thing.
Correct.
So, there's so many different things that can cause it. What else you got for seizures?
Oh, not too much more.
Yeah.
I think we fit that pretty good. Hopefully there was something
of value
in that whole conversation. Yeah. I had fun with it.
Yeah, that was a good conversation. There's a lot of good information. We may have rambled a little bit, but it's all good.
It is.
And some of our best content for you guys comes from us just sitting here BSing every now and again. But I'm excited for this next one, because it's kind of...
Oh, I am too. I know a little bit of it.
Yeah.
And I'm going to let you lead that.
Do you want to check your camera first real quick?
No.
Okay.
Yeah, we can.
Okay, so the next topic is controversial in so many different degrees of the world right now, because I am flabbergasted.
Yeah.
So this was all, and the thing is how public it was made was also flabbergasting to me, because like there was a lot of people out there that were like, oh my gosh, this is the greatest thing ever. And I'm sitting there like, are you guys in the dinosaur age?
That's what I thought too.
Like this is common practice and this isn't happening. Yeah. Like this is a common core of practice, like national core competency. And it was blowing me away. And so this came from,
say it.
This article was brought out by the University of Utah Health.
Mm-hmm.
And it was it's titled "Helping EMTs Save Kids with Breathing Emergencies." And when I think of breathing emergencies, I think of croup, epiglottitis, asthma, just any form of the restrictive lung disease process. Yeah. They're not going to be COPDs or emphysema, hopefully things like that. They're going to be patients that we're going to be giving albuterol, ipratropium to racemic epi, and all these things. Yeah. And I want to preface this a little bit that this wasn't not happening. It's just that I think, and this is another tangent that I can go on to, is like the division of the system, because I've spent a lot of time with a lot of those providers over there, the division of the system where the predominant 911 ambulance agency is BLS providers, and then you've got paramedics that show up on a fire truck. That is a heartburn for me, just for the fact that these two jobs are so different that they should be separated to a degree, because like if I was a firefighter paramedic and my love was fire, I would put the least amount of effort into my medical care.
Correct.
I am a paramedic who started in fire, absolutely hated fire, so I put all of my time and dedication into EMS. So I put all of my fire response to the side because I wasn't dedicating it enough to be of value.
Correct.
I didn't keep up on my certs. I didn't want to keep up on my certs. That's where my rant's going to end there, is that we have to find a way to delineate this a little bit. And so basically what's happening is there's this study going on. It's going to be called T-REX. And basically T-RECS. the medication use in the field. And basically what it says is what we're trying to figure out is if the treatments that we commonly use in the hospital for children who are experiencing symptoms of severe asthma, obstructive lung disease, can be used in the field. And those typical medications that they're using in the hospital are albuterol, dexamethasone, and ipratropium bromide. And if we use them earlier in the course of illness by first responders or by EMS providers and paramedics, if we can improve their overall outcome, that is a given. Are we even having this conversation right now?
I guess so. Yeah.
Like, how are we letting people who have a medical, either a degree, a certificate, or something that says that they can practice EMS medicine at a high level like a paramedic is, having the tools to be able to treat pediatrics and their respiratory distress, not doing this? Like, does that fall down to an agency not doing QA/QI? Like, hey, you didn't take this patient in that was having respiratory distress? Like,
I don't know.
Like, I don't know, Margot.
And why is the carpet all wet, Todd?
I don't know, Margot.
Like, I don't know, but it's just mind-blowing to me that we're even having this conversation. Is standard of care so low in some of these areas that I just don't know. Like,
I don't know either.
I'm generally curious, especially for this, man.
Especially for you. Like,
yeah.
Oh, it's annoying
but
because for us,
yeah.
we're taking a lot of our most critical patients, stuff that no one else can handle, all that kind of stuff over there. So you expect a high level of care. You expect all this kind of stuff. When I drop our closest level 1.
Yeah.
It's the place that we're going to go for the W2Fs and the bad stuff.
Yeah.
So
I do want to state that this is not a University of Utah health problem because they don't own the EMS agencies.
They don't.
The EMS agencies are all private and then fire-based backing. So this really, they're the ones producing this study and, like engaging in it to help provide this information, but they're not directly correlated to, the medical side of things that is provided. This is,
I guess that makes me feel a little better.
Yes. So taking that out, because this is not, a hospital thing. This is an EMS only thing and a fire-based thing because they don't own those agencies over there. The only agencies they have are Utah Health or Utah Air Med. Like they have their own air medical agency, and that's all they have in the EMS game.
Gotcha.
So we just have to clarify that and remember that that's part of that. But it doesn't change the fact that we have EMTs can give albuterol treatments.
Yeah.
Unless it's different in Utah, the standard of care in Idaho, it includes breathing treatments, continuous positive airway pressure. It can, IM epi. Some places are expanding into IV epi and cardiac arrest. They've got all of these things, glucagon, aspirin, nitro, this expanded scope of practice, and it's not happening. And I don't understand why. It's mind-blowing that we're even having this conversation.
I agree.
And the things that I don't understand is that, that they're having to explain this, that we're going to take care of your child like this is a medical study. Because in here, let me find the quote that I wanted to say is that, it is okay. So all paramedics that are going to be participating in this study are going to be getting training on how to kind of go through the workflow of treating these patients. We should know this.
You should obviously know that.
This is a given that we should know this. This is embarrassing. This is embarrassing for the EMS profession.
Absolutely.
And so one of the first steps is going to be, and I quote, "We are going to give these medications to your child because we think that your child needs these medications. You should also know this is part of a research study. They'll have a script and they'll tell the family member what's going on, giving them the option to opt in or opt out of life-saving medical treatment that we have been giving since 1985 when metered dose inhalers started in the world."
Yeah.
This is ridiculous.
A little bit.
This
a
is
lot of it. We're going to start doing this. Yeah, no shit. We've been doing it forever. Why is this a thing?
Yeah.
I don't get it.
I don't understand it whatsoever. Like, I I would love to hear from somebody that's going through this study. If you feel like contacting us, if there's anybody in the Utah area that knows more about this, I would love to hear about it, because the way that this is being worded to us makes me realize why we're paid little.
Oh, gosh.
I'm just being completely honest, man.
Got you.
Like, it is this shit that we have to go through that makes me realize why people view us on such a low pedestal.
Yeah.
Like, if we can't get ourselves together enough to not dump our ALS patient on a BLS provider in the back of an ambulance just so we can go back and do our thing, or like, sorry, I'm frustrated and trying to get this out, but I mean, like, or like just having the basic subset knowledge base to treat our patient, then like, how do we fix this? Like, I know we're trying to bring this awareness, but we keep running into roadblocks like this time after time again, where like we're puppy milling providers out, and they are not, I'm not trying to say this in a negative context, but it's making the profession not progress the way it should.
Yeah, absolutely. It totally holds us back, and it makes us look like idiots.
Yeah. Yeah. That, like, the thing at the end here, it's like, so the benefits of these medications are well known. They're medications that have been used for decades.
Yeah.
It states in there decades, and that are the definitive treatment for life-threatening wheezing and severe respiratory distress because of asthma.
Yeah, and everyone knows this. That's like why my kid was able to give herself her own Albuterol or nebulizer, no problem, at home without any supervision.
Yeah, and I mean, exactly. And like, yes, there are risks to every medication, but like, I think of it this way, because people will sit there and say like, well, I don't want to give epi to this asthma or to this allergic reaction because their heart rate's 160. Well, their heart rate's 160 because they're completely, vasodilated. Yeah. They can't breathe. Their face is swollen. So you give them medication. Yes, it's going to bump their heart rate, but it's ultimately going to fix the problem.
Correct.
Like, and that's a lot of these things in here. And it says like, there are side effects, yes, but like I said, these could save a child's life, and these are given facts, man.
Oh,
like, my gosh. And it's really frustrating. Like, it's very frustrating. Yeah. And in the case in that, the only thing that I could see even asking for an allergy to something like this, because we talked about this a little bit in the case review that I presented this week, was like, having an allergic reaction to a life-saving medication like this. Like, there are people that have allergic reactions to epi,
correct,
like to manufactured epinephrine.
They have, it's
weird.
They're allergic to like the preservatives inside of it. I've seen that before.
It happens. But remember in the old ipratropium bromide days where it was made in a different facility and we had to worry about nut allergies, like that was a thing. But that is a thing of the past for most producing companies, because most of the times we're going to get, a duo neb, which is the combination. They're all made in house. They're controlled. They're not in a nut oil facility of some sort, or they don't have that preservative in them.
Gotcha. There
are those times where like you'll still run into those warnings of like, not made in a nut-free area or something like that, or like be cautious of giving it to people with nut allergies. Like, but it's very, very slim.
Yeah.
And, even in that point, like, guess what epi does? It is a potent bronchodilator. If I give somebody a little bit of an allergic reaction because I gave them ipratropium bromide and I have to give them epi, now I have treated two things with one medication, but they're also still alive because they can breathe.
Yeah.
Like
deep breaths.
I would love to see racemic epi on more ambulances, though.
I agree.
To be completely honest, I think racemic epi is a wonderful drug. I'm very glad that we have it. I'm very glad that our ambulances have it, and that it's becoming of more of favor for our providers, because it does work incredibly well. I'm sliding down in my chair; it's a little slippery, but this was a heartburn for me, because I love watching our field progress, because there's times in my career where I've like, man, maybe I should just go to nursing school so I can, be.
Don't say that.
Yeah, I'm not gonna say that, but I'm not gonna do it,
because my wife's gonna listen and be like, "See, I told you."
Yeah, right. Because like it's things like this that keep us from progressing forward, and there's gonna be a lot of people hopefully fired up about this, and if they want to bad talk me for saying that we're losing progression because people don't know when to give Albuterol. Like, sit back and relax, ladies and gentlemen, because like this is exactly why we are the first people that these people who are having the worst day of their lives are having. And if we can't provide the level of service to our patients, we're doing them a disservice. And it's hard.
It is. And I've had a hard time focusing because all I can think about is a funny meme.
Go for it.
Because they call this the T-Rex.
Yeah.
And it's totally a joke, a LDS joke, a Mormon joke about basically sexual intercourse.
Probably cut this part.
I don't know. It's funny. It's hilarious. I gotta add it. I'm gonna add the meme, but it's what is it? Soaking.
Yes.
Basically, right? Soaking's not sex because you're not moving it around, and the meme is it just shows that God's a T-Rex, and if you hold really still, he can't see you doing it. So you're not breaking any rules there. But
oh man, that's
all
funny.
I can think about that whole conversation.
Oh
I'm
God,
sorry.
it's all good.
It's the T-Rex.
I'm over here getting pissed off at the world. You're thinking about T-Rexes.
And I was just T-Rexing it, and soaking, and dying.
Oh man,
but also very mad at this. Yes, when you first brought it up, I was
yeah.
like, "Are you kidding? That's going on the podcast?"
Yeah.
What ridiculousness. Like, how is that not obvious thing? Why is this even a study?
Yeah.
It makes zero sense that you're having to do this unless it's Utah saying, hey, EMS people, like, quit sucking.
Yeah.
Which is cool, but really we have to make a study and make us all look like idiots? My goodness.
And, it's crazy to see, like, how different agencies throughout different parts of the U.S. view, us as professionals, because we're very lucky. Because our medical directors are very progressive, and like we have all of our own. We don't use state set protocol. We use everything that our medical directors have put together that have been, evidence based, factual based, and everything in between to progress us. And then we just keep taking steps backwards, and all these people can go out there and say that we don't get paid enough to know this stuff. But as soon as you start knowing this stuff, it's time. That's when we can band together and ask for more money. It's just one of those things that, I don't know. It doesn't come down to money by any stretch of the imagination. But if we want to be viewed as a highly reliable, organization of EMS professionals throughout the world, then we have to step up our game. Like this.
Absolutely.
This is trash, man.
It is trash.
And I know there were some people that responded back to some of the Facebook posts were like, well, that's not really what it looks like. And no, it's exactly what it looks like. Yep. Like, do your job. I cannot stand. There's so many people in this world that will work harder at getting out of doing their job than just taking the patient. Yeah. And, that's a lot of what some of these random little studies come down to is they're using this to tell people that they have to do their job.
Oh, goodness.
But Jinx, you owe me a Coke.
I know.
I do have one last thing.
Okay.
What are we at for time?
We got time.
We got time. We always got time. Do you want to do a little? I found a question from a Facebook group if we want to cover it.
Yeah, do it.
All right. So
because I haven't heard it.
Yeah. So this is from this was posted on March 9th at 8:32 p.m. So fairly recently. Initials are PN. I accepted my first flight nurse position. Drop your advice as well as any booze, resource, book. I think he's trying to say books. Books, resources, and essential gear you think I need. It's a rotor wing position. And why don't we give old PN some advice from, some people that have done it for a little bit.
Yeah. Actually, it's one of my potential talking points was basically how to act even as a new flight provider.
I love that.
Right. So both as a nurse and a medic, and in quotations or one of the things I put in there was don't be cocky. Right.
Yeah.
Your very first flight job, like that's awesome. Congratulations, first of all.
Congratulations. Ring that bell.
When you go into that new position, wherever it is, flight, whatever it is, you're doing this for anybody, be willing to learn.
Yeah.
Like obviously you got hired for a reason. They're hoping you're going to bring something to the table, but you're going to have a lot to learn.
Yeah.
Especially when it comes to starting in flight, and especially as a nurse.
Yes.
So now you're out of the hospital, you're out in the real world.
You've got
right?
3 to 4 spinny blades of death above you at all times.
Right. Just learning the helicopter itself is crazy enough.
Yep.
But then how to actually do stuff outside of the hospital, how to do stuff with a partner who hopefully is a medic. I love the team nurse medic combo.
Yeah.
Because, again, as paramedics, we're out there. We know what it's like. And as a nurse, you're in there and you know what it's like. Hopefully you're bringing some of that critical care knowledge and experience. And that's what's super important, I think, for these flight teams is to have that. Because for us, I know how to move people.
Yeah.
I know how to get them out of point A and get them to point B, the hospital. Right.
With only losing one boot and a radio every now and again.
I lose radios all the time. Shut up. But and just in how we do that. So that's just one step. But then again, you're going into that completely different environment where it is not in the hospital. Things are going to be chaotic. I mean, you're going to have to deal with extrications.
Yeah.
Now. You're going to have to deal with fire departments and
cops.
And
bystanders.
Bystanders.
Oh man.
Yeah, absolutely. So it's completely different realm for the nurses.
Yeah.
And it's great that hopefully you know a lot of stuff, but remember there is a ton for you to learn. Mm-hmm. So just dig your heels in and learn, be accepting of that information, right?
Yeah.
Just don't be like, I already know that. No. Don't say that.
If
be
you
like,
know
okay.
it, prove it.
Like you can still learn something new.
Yeah.
From somebody else. So, and you can learn good and bad. That's one thing I've always tried to do is learn from everybody, whether that's good or bad, what to do, what not to do. So make sure you learn that and then share it as well.
Yeah.
So,
yeah, no, I think that's great. And one of the things that I try to tell new people that are coming from in a hospital is one of the things that they don't prepare in-hospital providers for is giving bad news and giving uncomfortable or having uncomfortable conversations with family and friends and all these things, because that's bred into us. Because when we do an infield death, we're the ones telling the spouse, we're the ones telling the friends, the family, making that phone call and letting them know who we are by first and last name, what agency we work for, and that their family member has died. And, getting into those uncomfortable conversations is really hard because a lot of the times, like, the provider is going to be doing that inside the hospital. But now you're the provider on the outside of the hospital, and being able to talk to people in a confident, doesn't have to be elegant way or anything like that, but in a confident way, like, I'm sorry that that this has happened. We did everything that we could. Plus some that sometimes that the ER doesn't go through. And a lot of the times we overwork our cardiac arrest, to be completely honest. And, I am very sorry to tell you, but, Todd is dead. They have died, they have passed, or died's fine, but they have passed on or things like that. But saying these uncomfortable words in front of families is really hard. So practice these things so it doesn't sneak up to you on your first, out of hospital cardiac arrest, and your paramedic's like, hey, I ran this shit show already. You go talk to the family.
Because we're pretty happy to pass that on. Because we do it all the time. So it's your turn.
Part of our career. It's having difficult conversations is part of our initial education. So I'm always glad to see new people come in, but we have to learn how to have, because watching some of these 18-year-old, 19-year-old paramedics coming straight out of school, trying to have these conversations, I'm like, ooh,
I remember some of those.
And we were all there, but we get better at it over time.
You
right?
Do.
But so that's kind of one of my big things, but some of the resources that are available, we do have books available, but there are also lots of good books, like the Critical Care Transport AOS. There's a lot of other agencies out there, and education companies that have very solid resources as well. But some essential gear that I think of, I'm a
chesticle.
Yeah, I love my chesticle. To be honest, I keep a tape measure in there to get my ideal body weight, because I don't like a guessing game when it comes down to ventilator settings. So a tape measure is always good. Keep a headlamp with me. I've got my overnight baggie. So like if we have to get stuck somewhere or like I get left somewhere, I've always got a jacket and underlayer. I've got a Leatherman, an extra bottle of water, and a snack, basically.
That's my main thing for me is snacks.
Yeah.
Diabetes.
Yeah.
But and pens.
Yeah, pens are always good.
You
Find
always
your good
lose
pen.
pens.
Pilot G2 for life.
G2 for life.
Yeah,
for
not a
sure. The only
sponsor.
bad thing is that I lose them.
Yeah, and they're expensive, man. When you lose them, they're expensive. Usually it's your nurse stealing it from you, but
there is that. That happens quite a bit
So,
as well.
let's see what other people have said. Be comfortable being uncomfortable. I love that.
Mm-hmm.
That's really good. Slow is smooth and smooth is fast. Grab yourself a multi-tool and a flashlight. You'll need them and use them. Ask questions. Be teachable. I really like that.
Yep, be teachable. Absolutely.
Be teachable is
kind of
huge.
what I was trying to get at.
Yeah.
That's just an easier, better way of saying it. Be teachable. And then another thing, too, that I thought of, too, was just when you're going into now seeing calls in different environments is pay attention to that environment.
Situational awareness.
Situational awareness. Don't box yourself in.
Yep. Know your exits.
Yep.
All the
And
things.
Look for weapons because they're always there.
Maybe play the game for your first 50 scene flights of playing how many weapons can I find in this house as I walk in the door. Because it's impressive what you find.
Oh, yeah, all the time.
Like, we have learned from the movie Tangled that a frying pan is a weapon.
That's right. Who knew?
Don't spend $5,000 on a fancy helmet. I agree and disagree. Right off the bat, not necessary. Most agencies will provide you with one. But if you tend to keep this as a lifelong career, a fancy helmet is very nice because I like my hearing.
Hearing is good. Yeah, Bluetooth headsets with noise canceling.
Yeah,
be awesome.
I'm jealous that I don't have one
yet.
But, I'm going on.
Someday.
Yeah, one of these days I'll find one that I like. Beef jerky in your pocket at all times. Always a great thing. The most important thing for you and your career is invest in great hearing protection. Getting your own quality helmet. Be confident in what you already know, but be humble enough to be teachable. I like that. That's that confidence over competence side of things. And let's see. Don't be afraid to call for a stop. Ooh, I like that one.
Yeah.
If you don't like something, say it.
Yep.
Like it's 3 to go, 1 to say no, pretty much at every agency that you'll ever work for. And if you don't like something that's happening with your patient, if you say stop, all paramedics are going to stop because like that's kind of a bred into us thing. Yeah. And it's okay to slow down every once in a while.
Yep.
Let's see. Look at a couple other little random ones here. Lots of congratulations, lots of really good things. Proofread your charts and narratives. I learned that one the hard way because one of my EMTs put in a funny, and I didn't go back and change it. It was just like, it was something ridiculous that they put in there that I passed on to the supervisor, and they're like, "Did you read this?" I'm just like, I
used to have to reread mine in the morning because I would sleep chart.
Oh yes, sleep charting's the worst.
Dream chart. When I start charting your dreams, that's always fun.
One of the things that I like to do is I use chart dictation quite a bit. I just open up my chart on my phone, and we'll hit the little voice to text and dictate on the way back, or when I get back to base, and then just go through and proofread it. That
definitely
saves some time.
Series dumb.
Yep, and postdictal is very poetical.
Yes.
So. But yeah, no, there's a lot of things that coming into it as a new provider, everybody's going to be different. Like I hate things in my pockets. Like that's why I wear my little chest desk. That way I just have all my stuff there. Like I like to be comfortable. And then, good underclothing, because if you're in a place where it's super hot and you're in a flight suit and you have to hike, I'm a huge fan of like, if we're down and we're going to be there for a while, I'm going to take my flight suit off to hike through the mucky wilderness and up through the mountains and things like that. I might throw it in my backpack or something, but I always have hiking shorts and a nice t-shirt on underneath to, offload some of that heat that I'm going to expend when I'm hiking in 102 degrees at altitude. So
definitely, because you never know when you need that half of your t-shirt for some toilet paper. So.
Oh, that's another thing too, is if you have to pee, like I am a chronic peer. Like I pee at every leg of my transports. Yes. Like I pee before I leave. I pee when I get to the sending hospital. Sometimes I won't pee on scene calls, but you never know, the need might arise. Like,
been there, done that.
But like, if you are so uncomfortable, you have to go to the bathroom. I'd rather not get post-renal disease from, having to pee so bad. Like if we're flying back from a hospital and, my pilot's okay setting down, like, and I have to pee out in the wilderness somewhere, like, so be it. Like when nature calls, and they'd much rather you not shit your pants in the back of their $7 million helicopter. So be prepared for some of the unexpected things. I do keep ODTs over, and I don't get sick hardly at all. Like, but there are some hot days where, like, if I haven't eaten, we've been going back to back to back to back, I might pop an ODT Zofran. I just get it from my doctor. Like, it's not a big deal.
Yeah.
Like, they're usually pretty chill about that.
I typically only get nauseous when it's really hot, or if I'm doing like night searches, NVG goggles, my head's down and I'm looking outside and we're just sitting there going around in a circle, basically trying to find somebody, then I'll get that usually will make me nauseous.
Yeah. And if you're going to be that's a good point. Like get used to NVGs. Like I am a huge fan of NVGs. Like I don't have an issue wearing them. Like I don't have to have a weight. Like my head's big enough most of the time that it offsets the weight. But, some of the things that if you're going to be at a single base most of the time, like I keep my locker, stocked with, I've got ibuprofen. Allergy medicine is huge during the summertime for me because I have really bad like seasonal allergies. So I pop an allergy pill every morning, and Pepto-Bismol is always great. Things that we don't think about. But I also keep like the thing that I do when I first wake up every morning is I brush my teeth. I keep a spare toothbrush, toothpaste, just little odds and ends, fingernail clippers and random stuff like that. Like your company should provide you with a safety kit in your aircraft. Get familiar with that.
Yes.
Learn how to start a fire, please. You learn how to collect water, how to do the random things, use the stars to find the North Star. I mean, like, get comfortable with your equipment, and ventilators are not benign. So do lots and lots of research. Just because you've been in a hospital and around them does not make you know how to use them.
Correct. So, absolutely. Learn your ventilator.
Cardiac monitor is the same way. Like depending on what they're using, whether it's like a Tempest or a Zoll. I don't know if LifePak is capable of flying. I can't remember or not, but either way, that thing's heavy in a brick. So, but yeah, learn your monitoring equipment, learn your radios, make your life easy in the beginning by, kind of drowning yourself. I hate to say it in education, but it just pays off in the end.
It does. But with that, I think we might have to end it.
Yeah.
Been going a while.
Yep.
It's been fun. We learned about seizures. We learned about stupid studies. And
take some time. Think about how we can progress our career, because I feel like we're doing our part by trying to bring this out, but we need to, continue pushing people. So if you guys have any ideas, let us know.
That's right. We're going on strike. No, I'm just kidding.
Bosses, don't listen to us. You all listen to these episodes anyways, so don't listen to that part.
No, we appreciate you guys.
Yeah.
Don't forget to check out our stuff.
Buy a book.
If you like it, share it. Buy a book. Buy a course. Get after it. Get some good education. Have some fun with us. And thank you guys. We will talk to you on the next one.
Adios.